Yeah, good morning, everyone. And I'm Dr. Yuxiang from Zhongshan Hospital in Shanghai. My complex case was about the selection of unconventional collateral for retrograde approach in coronary CTOs. As you see, coronary collateral is actually in situation of CTO is actually the gift from God, and appropriate intervention collateral means suitable to deliver interventional equipment from the donor vessel to the target vessel. So about 64% of the patients had really interventional collateral. And retrograde CTO PCI is possible in above 50% of patients. Of course, this is according to the experience of the operators. So the types of collateral that can be used for retrograde crossing include the bypass, septal, and epicardial. Different from the bypass and septal collaterals, epicardial collaterals is often very, very tortuous and difficult for wiring and unable to dilate. Also, it has high risk for templator. So, according to the Vernal classification of CC, CC0 means without a visible connection with the recipient vessel, and CC1 means thread-like tiny vessels, and CC2 means servo vessel-like channels. So the optimal collaterals have a risk below, characteristics below for including septal side, adequate side branch size, obtuse angle of exit and entry, and no tortuosity, and adequate retrograde attack distance, which is very, very important for our retrograde attack. And this is a brief introduction of our presenting case. This is a young gentleman who is 42 years old, and chest pain after exercise for 3 years. The ECG showed V3 to V6 lead T-wave inversion, and echo showed a segmental hypokinesia of the anterior wall with LVEF 46% and risk factors including hypertension, diabetes, and cigarette smoking. And you can see from the left coronary angiography, and you can see very severe stenosis of the proximal LAD, and followed by total occlusion. The total occlusion just begins after the branch of septal, and you can see this is RCA. That's relatively normal of the RCA and very good collateral to middle LAD. And for actually detailed imaging, you can see there's some potential collateral from RCA to LAD, including both septal collateral and epicardial collateral. And this is bilateral angiography. You can see that the total occluded segment is not very, very long, about just 10 to 20 millimeter. However, maybe the entry of the CTO is very, very tortuous. And first of all, according to CTO pathway, we performed the antegrade approach first. And however, after attempt for Gaia first, UB3, Gaia third, respectively, we find from the contralateral angiogram, you can see that the wire was not in the true lumen. And then we turn to retrograde approach. According to the study in 2016, the most frequent septal used in retrograde approach for LAD CTO is the PDS septal to LAD, and then followed by the epicardial the collateral from RV branch to LAD. And in the right image, you can see that this is the potential collateral that can be used in this case. And the first two is the septal branch from PDA to LAD. And however, there is a very, very good collateral, however, very, very tortuous from the RV marginal to septal and then to distal LAD. So the key points for collateral vessel imaging interpretation include and before they review the image repeatedly, frame by frame, sometimes the key image are only have 1 to 2 frames and do not be satisfied with finding just one potential channel. Perform angiography from multiple angles and select the appropriate projection position, and use the MC for tip injection angiography. Remember the path of the channel, as the channel often cannot be visualized once the guide wire inserted. And then we choose the PDA to septal collateral first. However, and it was not very good. And the tips for passing septal collateral, including the below, I think most important is that for septal collaterals that are not continuous in angiography, we can still try. So, and in this case, we tried many times for the PDA to septal to collateral to LAD. As you see, it seems as if the collateral from the septal collateral is continuously connected. However, there are some very tiny twisty in the middle segment, so that's why we used a very soft 0.3 grain wire and cannot pass. Also, we tried a surfing technique to use some CC0 grade collateral. However, we failed. So next we turn to the RV marginal to septal collateral, because this is very tortuous, and we suppose we should need extra support. So we used the extending catheter for retrograde guiding, and the tips for passing the tortuous epicardial channel, as I showed as follow. The most important is pay attention to the small branch, and this is which often causes the perforation. And you can see this is a very tortuous collateral. After gentle handle, we used a 0.3 grain wire. At last, it passed through the collateral. And then we faced another problem. The MC cannot pass through, and we changed from the routing MC to another new MC made in China, and finally it passed. And then we used a switch to stiff guide wire for retrograde attack. However, UB3 and Gaia third failed, and last we succeed in P2200. And then we one more minutes. Okay. Thank you. And how can I try? Sorry. Okay. So, and then we used the active greeting technique, AGT technique, proposed by Professor Ge Junbo in 2020. We deep inserted the extending catheter to proximal LAD with the help of a 2.5 balloon. And after the dilation of the antegrade balloon and the retrograde pilot 200 guide wires, very easy to enter the antegrade extending catheter very soon, just 30 seconds. And then we by anchoring the antegrade wire, we advanced the retrograde MC to antegrade, and then we via the help of dual balloon microcatheter, we advanced the workhorse to integrate to distal LAD, and then the routine IVUS was performed, and we can see the wire was totally in the true lumen. However, there are some hematoma in middle segment, and 2 stent was implanted, and that's the final result. It's quite good, and you can see retrograde channel crossing, even for epicardial collateral with very tortuous, we can cross the lesion, cross the collateral by very gentle handling. Thank you. That's all.